Hello everyone, welcome to HIM 216. This is a continuation and the final lecture for Chapter 5 in your textbook. Please turn to page 94 in your textbook, and we'll be finishing up these last few guidelines, and then I have a PowerPoint presentation that we're going to go over, and I think that will also help you with the test covering Chapter 5, which is a critical assignment. On page 94, we're looking at the guideline for admission from an observation unit. And just to remind you, when we're looking at the coding guidelines, we're in section 2, and this is actually guideline I. We're looking if a patient, now to be very clear again and remind you, observation is an outpatient status. So we're talking, in this guideline, they're talking about a patient who is admitted to observation, which is an outpatient status, for a medical condition. Let's say that they have a chest pain, and that condition either worsens or it does not improve. So they are subsequently admitted as an inpatient to the same hospital with the same medical condition. That principal diagnosis would be the medical condition which led to the hospital admission. So in this example, the patient comes in for observation because of chest pain. And I want to demonstrate for you that chest pain is actually a sign and symptom. There are some very specific locations for chest pain. Sometimes you'll see musculoskeletal chest pain documented. Sometimes you'll see atypical chest pain documented, but just plain old chest pain is R07.9. It's in Chapter 18. That's a sign and a symptom. Many times when patients are in an observation status, they're in because of a sign and symptom, and then once they work them up, they come up with a definitive diagnosis, and then they admit them. So in this particular example, the patient came in because of chest pain, but after they started testing this patient, they determined that this patient had a myocardial infarction. This NSTEMI is a non-ST elevation myocardial infarction. And actually, if I go to infarction, myocardial, let me get there. See where this says non-ST elevation, NSTEMI. If it's an ST elevation, they call it a STEMI, an STEMI, and that code is I21.4. So in this case, this patient progressed in observation for chest pain, did the workup, found that the patient had had an NSTEMI, and so they admit that patient for treatment of that myocardial infarction. Now, another scenario that involves an outpatient setting is number 2. A patient comes into an observation unit to monitor a condition or a complication that developed following outpatient surgery, and then they're admitted as an inpatient to the same hospital. What we're going to do there is apply the definition of the principal diagnosis to that admission. So let's say that a patient has outpatient surgery, and while they're in the recovery room, they go into congestive heart failure. Well, the condition that will occasion the admission is the congestive heart failure. Now, 2 is different than J. In number 2, this patient they had outpatient surgery, and then they were placed into an observation status from outpatient surgery, and then subsequently they were admitted as an inpatient. In J, this is when the patient receives surgery and is admitted for continuing inpatient care at the same hospital. And this actually occurs fairly often. And so when we look at these, if the reason that the inpatient if the reason for that admission is a complication, then you assign the complication as the principal diagnosis. If no complication or other condition is documented as the reason for that admission, then you assign the reason for the outpatient surgery as the principal diagnosis. If the reason for the inpatient admission is another condition unrelated to the surgery, then you assign the unrelated condition as the principal diagnosis. So let's talk about some examples with this. So if the reason for that admission is a complication, you're going to assign the complication. So if you have a patient who's in outpatient surgery and they're admitted from outpatient surgery to an inpatient status, let's say that while they are in recovery, they have a myocardial infarction. Well, there's no reason that that patient would be put into observation and then go from observation to inpatient. The fact that they had an MI following surgery definitely meets criteria for admission, and they would go from outpatient surgery to inpatient. Let's say that a patient comes in for a scheduled, they call it a scheduled outpatient procedure. Let's say they come in for a knee replacement. Now, many times patients are not admitted to the hospital the night before their surgery. They bring them in the day of the surgery very early in the morning. And that whole any lab work that needed to be done, any exams, any procedures like EKGs or chest x-rays, those are all done a few days before, usually they have to be done within a 72-hour period. So they bring that patient in the day of the procedure. They call it outpatient surgery, knowing that that patient will be admitted after the knee replacement. They do the surgery and the patient immediately goes to the floor, and they're an inpatient for maybe 4 or 5 days. Then in the next example, maybe there is a condition unrelated to the surgery. So let's say that the patient comes in for, to have their cataracts extracted. They come in and have a phacoemulsification with a lens implant. And while they are in recovery, their blood sugar spikes. And it would be more likely that maybe their blood pressure becomes very accelerated and they can't control it with medications, so they are admitted as an inpatient. Or maybe while they're in the recovery area, they go into respiratory failure and they're admitted as an inpatient. So the difference between I2 and J on page 94 is in number 2, they were in observation following their outpatient surgery. In J, they're being admitted from outpatient surgery. They're not going to observation first. Now, if we look at this example on the bottom of page 94, this patient had an outpatient esophagogastroduodenoscopy, and we call this an EGD. And you'll see it called EGD all day long, but that's what it is, esophagogastroduodenoscopy. So they use a scope and they go down and they look at the esophagus, they look at the stomach, and they look at the duodenum. And the reason that they're performing this procedure is this patient has gastroesophageal reflux. Now, the patient goes into atrial fib in the recovery room and they were admitted to inpatient status. So this is an example of a outpatient surgery to inpatient. So the physician does document that the atrial fib is a complication of the procedure. And we can look this procedure up. We'll have a complication code as our first listed diagnosis. So if I go to complication and then surgical procedure on, I'm going to see digestive system. And oh, this is not quite where I want to be. So actually, this complication happened in the recovery room. So it's actually a post-operative or post, if I go to post-operative, it says see complication post-procedural. So when I look at post-procedural, what happened to my patient is they had a cardiac functional disturbance. It was not, this patient did not have cardiac surgery, it was other surgery. So that makes my code I97.191. And that's the principal diagnosis code for this patient. And then we're also going to code the complication that occurred is the atrial fibrillation, which is I48.91. And then we're also coding the reflux, and this is gastroesophageal K21.9. Then you'll see we have a couple of Y codes. These are external cause codes. This Y83.8 let's see if we can surgical operation. Let's click here and see if that takes us where we want to go. Let's look at Y83.9 because we know we're going to be at Y83.8, other surgical procedure as the cause of abnormal reaction of the patient, or of later complication without mention of misadventure at the time of the procedure. So what is the difference in these? This is other surgical procedures and this is surgical procedure. I'm not exactly sure what the difference in those codes is. Other surgical versus surgical. This patient was having an EGD. That's considered a surgical procedure. I won't get started on Y codes. And then this Y92 is a place of occurrence code. And whoops, I have to get into the and this place of occurrence is actually at the hospital. And if I'm in external cause, I just type in, and we'll go over this in detail next semester, hospital Y92.239. It didn't actually happen in the operating room. It happened in the recovery room. They're using the code specified NEC, which is perfectly appropriate for this. It really doesn't tell you anything more than Y92.239. And then we have the procedure for this, which is they were having an EGD. So I can actually put in this index, I can put in EGD, and it will actually it will give me the full code and take me right to the table. And again, we're going to go over this in detail in Chapter 6 in just a week. So that is that example for you. Now, on the top of page 95, it goes over the guidelines for admission to rehab. And basically, there are two scenarios that typically happen when a patient's admitted for rehab. And this would be admission to a rehab facility. And if the purpose of the admission is rehab, the first code that you sequence is the condition for which the service is being performed. So let's say that the patient is being admitted to rehab because they have had a stroke and they have hemiplegia. And so the code that you would report would actually be the I-69 code that reflects that the patient has a sequela of a CVA and what that sequela is. Now, there's another condition that may be resolved. So let's say the condition is being performed for, the rehab is being performed for a condition that the patient no longer has. And in that instance, you would use an aftercare code. And the example they have is that a patient had severe degenerative osteoarthritis, so they underwent a hip replacement. Well, they don't have osteoarthritis in their hip anymore because it has been replaced. So we would go to aftercare and in following surgery for, and then there are you have many different options here. But that's the example that is being talked about there. Now we're going to talk about reporting additional diagnoses. And this is not different from what we have looked at before. We report other diagnoses if they require clinical evaluation, therapeutic treatment, diagnostic procedures, if they extend the length of stay, or if they increase nursing care. And we also report previous conditions if they're documented on the discharge summary in the face sheet. But if they have no bearing on the current stay, they are not coded. And you can see history of codes, which are in the range of Z80 through Z87, can be used as secondary codes. So in this example, the patient is being treated for congestive heart failure, and they have a history of allergy to shellfish. There is a code for history, personal history of a shellfish allergy, but you really wouldn't assign a code for that unless the facility policy directed you to do so. And so in this example, the only code we would be coding is the code for the congestive heart failure. In this next example on the top of page 96, the patient is being treated for prostate cancer. There is a significant family history of prostate cancer, and so we would assign the code for the prostate cancer, C61, and then we would assign the history of code. And when we look at history codes, you'll see, why did they do that to me? When we look at history of codes, you'll see that the first indentation, the first subterm is family. And so we can do, after we do history, we have to do family, and then we probably have to do malignant neoplasm of prostate, Z80.42. Now, if we are coding a personal history of, we have to do history and then personal, and then we can do malignant neoplasm of, and if it were prostate, then we could go down and actually choose prostate, Z85.46. So we'll go over this in more detail, but when you are coding history of codes, you have to be very careful of whether you're getting a family history code or a personal history code. And of course, you're always going to read the definition of the code and the category, and clearly if it was personal history and you were choosing a category that said family history, you would know that you had the wrong code. Let's talk about abnormal findings, which is B. We have talked about this before, but abnormal findings, and these would be abnormal findings that you might find on a lab report or an x-ray report, maybe a pathology report or some other diagnostic report, but they are not coded or reported unless the provider indicates their clinical significance. So if you see a lab work and there's a very low hematocrit on there, you can't assume that the patient has anemia. And just because the physician checkmarks it doesn't mean that it has clinical significance. If the physician actually has ordered testing to evaluate it, or he has treated it, then you can generate a query to ask him about the clinical significance. If the physician doesn't address it anywhere, query guidance says don't even query him. Now, there's a note here. Please note this difference from coding practice in the outpatient setting. In the outpatient setting, if the test has been interpreted by a provider, you code from it. So when we look at outpatient coding guidelines, we'll see that that is a significant difference. So in this example, second example on page 96, potassium is low. Potassium was ordered, so in this instance we can query the physician for the significance of that abnormal lab value. And then number C, uncertain diagnoses. And this guideline, possible, probable, rule out, still to be ruled out. There is a difference in rule out and ruled out. R-U-L-E out and R-U-L-E-D out. If I want to rule out pneumonia, it means that I don't know whether the patient has it or not. If I say that pneumonia was ruled out, R-U-L-E-D out, it means that I have decided the patient did not have pneumonia. You will often see physicians document a diagnosis as being ruled, R-U-L-E-D, out. It means that they were considering the fact that the patient may have had that condition, and they determined that the patient did not have the condition, so they ruled it out. So that is quite a difference in the terminology, and you need to make sure you understand that. And then the example here is suspected aspiration pneumonia. That is coded as though that patient had aspiration pneumonia. Now I want to go over some scenarios that talk about the selection of the principal diagnosis. And in this first question, our scenario is that a patient's admitted. Oh, by the way, your question for this lecture, I want you to look at guideline 2H, which is uncertain diagnoses as selection of the principal diagnosis, and guideline 3C, which is uncertain diagnoses as a secondary diagnosis. And I want you to tell me if there is any difference in those two guidelines. So read section 2H and then read section 3C and tell me if there's a difference. So you will have scenarios like the one you see on your screen on your test. So this patient's admitted to the hospital due to fibroids of the uterus, and they're coming in for a hysterectomy. So in the OR, before there's an incision, the patient develops respiratory arrest and the procedure is canceled. So the question is, what is the principal diagnosis and what is the guideline? Well, the principal diagnosis for this case is going to be the fibroids of the uterus. They planned a hysterectomy, but they didn't do it. We can't code a hysterectomy if, in fact, it's not ever done. So, the definition of the principal diagnosis is not changed because this patient develops respiratory distress. The condition determined to have occasioned the admission to the hospital is the fibroids of the uterus. Respiratory distress is a secondary diagnosis. And even though that procedure is canceled, it does not affect the selection of the principal diagnosis. And if you look in your book on page 95, actually, no, it's on 93, so section 2F, that's the guideline that supports the selection of this principal diagnosis. Now in this next example, the patient comes in with acute abdominal pain They can't eat, they can't drink, they have a fever. The discharge summary says that the patient has either acute cholecystitis or acute pancreatitis, and both of those conditions are equally treated. So what is that principal diagnosis? Well, there is one and only one principal diagnosis. In this instance, it is either the acute cholecystitis or the acute pancreatitis. Either of those can be the principal diagnosis. It is not acute cholecystitis and acute pancreatitis. That statement implies that there are two principal diagnoses, and there can only be one principal diagnosis. So if you look at section 2C, that is the guideline that tells us that either of those can be the principal diagnosis, but not both of them. So in this next example, a patient with known hypertension and type 2 diabetes is admitted for treatment of congestive heart failure. On the third day of hospitalization, the patient develops hyperglycemia with a blood sugar of 600. What's the principal diagnosis? What is the guideline? Well, the congestive heart failure is the condition that meets the definition of the principal diagnosis. The condition determined to have occasioned the admission is congestive heart failure. So even though that patient is a type 2 diabetic who becomes uncontrolled, and we call it hyperglycemia when we're coding it, with that blood sugar of 600 on day 3, that does not change the principal diagnosis. The condition that occasioned that admission is the congestive heart failure. Even if this patient had a myocardial infarction on day 2 or day 3, that would not change the principal diagnosis. And this guideline is the very beginning, the section 2, selection of principal diagnosis, because this is talking about the definition and how you choose it. Now in this one, a patient's admitted with severe abdominal pain. Exam and workup reveal a perforated peptic ulcer. On day 3 following admission, the patient develops acute pancreatitis. So what's the principal diagnosis? What is the guideline? The principal diagnosis is going to be that perforated peptic ulcer. Very probably with a perforated peptic ulcer, they have to do surgery on this patient, and they have to go in and do a gastric resection for that. The fact that this patient develops acute pancreatitis does not change the principal diagnosis. There is not any condition, the condition that occasioned this admission is the ulcer. It doesn't matter what else happens during this admission, it will not change the fact that the ulcer is the condition that occasioned the admission. Even if this patient had an MI after surgery, or if they went into respiratory failure, it would not change the principal diagnosis. And again, this is from section 2 for the definition of the principal diagnosis. Now I want to just briefly talk about the test that you're going to be having for Chapter 5. This test is 25 questions. It's true, false, and multiple choice, and fill in the blank and coding. You're going to be using 3M for the coding questions on this test. You need to make a minimum grade of 75 on this, or you will complete a test autopsy, which is an assignment that I will assign to individual students who do not make a 75 on this test. There are questions on this test that ask you for a diagnosis, and that is not a code, but it is the narrative diagnosis that's based on that scenario that's provided, like the ones that we just did with that PowerPoint presentation. And this test, you're allowed 90 minutes to complete this test. You need to understand and know this information that's in Chapter 5. You need to know what the definition of a principal diagnosis is. You need to know how to code signs and symptoms. What are those guidelines for coding signs and symptoms? You need to know how to code the uncertain diagnoses, possible, probable, and rule out. You need to know about coding conditions that are integral to a diagnosis. Do we code them? Do we not code them? How do we code acute and chronic conditions? How do we code this scenario when a patient's admitted following surgery and has a complication? How do you code etiology manifestations? How many codes does it take to code etiology manifestations? And what is a sequela? So you need to be very familiar with this chapter and the guidelines that we have covered in your textbook so far.